do a little overview on the anatomy of the thyroid and parathyroid glands. You can see the picture here, pretty self-explanatory. And then what is a total thyroidectomy? So it's a minimally invasive procedure. It's where the entire thyroid is completely removed, and typically it's just a small horizontal incision. They also have a new procedure out that's very minimal precision and incision, and they're able to do it where there's basically no scar left through different types of techniques. But this is the most common, is the total thyroidectomy. So what indicates a thyroidectomy? Well, that would be thyroid cancer, hyperthyroidism, a goiter, anything causing an obstruction when you're swallowing or breathing. Those are typically the most common reasons why you would get rid of it. Risks of the operation: there's always risk, bleeding, low blood calcium, recurrent laryngeal nerve injuries. All of these are minimal risks, but they are a risk. So how do you guys as nurse practitioners care for these patients, pre-op and post-operatively? So preoperatively, the management is you need to obtain the calcium, the albumin, and the parathyroid hormone lab values. Then, after they're out of surgery, you need to obtain the following: the calcium and parathyroid hormones. And these are what's going to guide how you treat them and what medications and the doses that you put them on. And the reason being for the parathyroid hormone is that when they remove the thyroid, they also remove the glands, where then the parathyroid hormone goes out of your system within 10 minutes. And the level is supposed to drop by 50%. And if it drops by 50%, it's considered a curable diagnosis for removing the full thyroidectomy, and it was worthwhile. So that is why when we get to the chart, you will see the parathyroid hormone needs to drop 50% from the initial level that they drew prior to surgery. So normal lab values, always need to know your normals before you're able to identify what is high or low. So parathyroid hormone is going to be 10 to 55. Your calcium is going to be 8.5 to 10.2 approximately. So post-op management, you're going to start with your calcium carbonate and or calcitriol, if indicated on most recent corrected calcium and parathyroid hormones. You're going to give patient medication as soon as cleared to take PO. You can give things IV if necessary if their levels are critical, but majority of the time you're going to want to try to get them on PO very quickly. So next action is to look at your calcium and parathyroid hormone levels. So you'll see on your sheet that the first one we're going to look at is if your calcium is between the levels of 8.6 and 11. So if their calcium is 8.6 to 11, their parathyroid hormone is greater than or equal to 15, and it's dropped less than 50% from the original parathyroid hormone level, then you're going to not start any medications. So you're not going to start calcium carbonate or the calcitriol. Instead, you're just going to check the calcium for every 6 hours and check the parathyroid hormone every 6 hours post-op and every morning until they're discharged. Then you're going to continue to adjust medications based on their most recent calcium and parathyroid hormone levels that you get. So that's the best case scenario, minimal that you have to do. But then if their calcium is between 8 and 8.5 and their parathyroid hormone is greater than or equal to 15, as well as the parathyroid hormone drops less than 50%, you're going to do a low dose of calcium carbonate 3 times a day and no calcitriol. Then you're going to check the calcium and the parathyroid hormones every 6 hours and then continue as needed based upon those levels. Next, if your calcium is between 8 and 8.5 and your parathyroid hormone is less than 15, or the parathyroid hormone drops greater than or equal to 50%, you're going to do a low dose of calcium carbonate 3 times a day, as well as you're going to start calcitriol twice a day, and you're going to consult with endocrine. Again, you'll check the lab values every 6 hours, continue on, consult with endocrine, and proceed as lab values show you. And then if your calcium is between 7 and 7.9, then you have any parathyroid hormone level, does not matter at that point. You are going to do high-dose calcium carbonate 4 times a day. You're going to start calcitriol twice a day, and you're going to consult endocrine. Again, monitor the labs every 6 hours and continue to adjust the medications based upon the lab values that you're getting. And then if you have a calcium less than 7 and any results for high-dose calcium carbonate, start calcitriol 3 times a day, consult endocrine, and check the calcium every hour after infusion, and get an EKG immediately. So that's going to be the one that has the most extreme measures that you take. So for dosing, the calcium gluconate, you're going to do 100 to 200 milligrams per kilogram IV over 60 minutes. The max dose is 2,000 milligrams. And then your calcitriol is, you don't start at 0.5 micrograms per dose and increase to a max of 2 micrograms per day. The calcium carbonate, your low dose is going to be 100 milligrams per kilogram per day to be taken 3 times a day, and your high dose is going to be 250 milligrams per kilogram per day taken 4 times a day. So in order to discharge these patients, their calcium has to be stable and not decreasing, and the patient has not required any calcium gluconate in the last 24 hours. So that is the PCH general surgery golden standard for discharge for these patients. So what you need to do in order to accomplish the discharge to get set up for them is you need to provide the patient with a lab order to obtain their calcium and albumin and parathyroid hormone 3 to 5 days after discharge. They need to stay on the lab slip to call endocrine. The phone number is on the screen if they have not received the results, to ensure that they are going to get to know that the results and follow through with that if there's anything critical. They need to notify the primary endocrinologist prior to discharge and arrange follow-up appointments. Patient discharge instructions will include follow-up appointment for endocrinology as well as surgery. If they don't hear about the lab results, to call them within 24 to 48 hours to ensure that their lab values were in range. And if their child develops any tingling around the mouth, tongue, lips, fingers, or toes, or develops any muscle cramps, then they need to call their doctor immediately or go to the ED as soon as possible. So, other than that, that is it.
Any questions? What about instructions for when they have numbness or tingling of their face, fingers, or tongue?
Well, if they're low on calcium, most likely, so they immediately need to come to the emergency department to get treated for that.
What can you do in the meantime until they get here?
Take a calcium tablet if they have it.
There you go. So in our discharge instructions, we also have that as part of, to come in, but to tell them how many to take, so that by the time they get here, it's not even lower, so we're not totally behind the 8 ball.
Right.
So, other than that, quick job.
What is the albumin drawn for? That's for pre-surgery, so to see the vasculature and how the fluid is moving in and out and where it is. Okay. So post-operatively, do we need to check that? You know, that is something that I was not so certain about either, but it is in the protocol to check it. Okay. So that's a question for the higher up. All right, I will actually find that out. No, I don't.
Oh, yeah.
Oh, great.
Because if it's low and you're concerned if it's actually low or not, you can correct it using the albumin, because albumin is a carrier for calcium.
Perfect. There we go. Thank
If
you.
your albumin is low and your calcium is low, it's likely that they're both actually low.
Okay, perfect.
You can use it. I don't know the calculation by heart, but you can look it up and then you just put in the numbers and it'll tell you if the ionized like the actual calcium.
Available calcium is low versus. Okay, got it. Thank you.
Jim Shea probably has that in his head.
Oh, I'm sure he does.
Any other questions? No, actually I do have another question for you. If their calcium is low, below 7, why do I need to get an EKG? Heart, to see how well it's contracting.
Do you happen to know on the EKG what you would be looking for?
No. Not off the top of my head.
Me neither. But I do remember learning him.
Think about it. Think of your pediatric PALS certification. what rhythms do you always, if you see it, you give calcium immediately?
It's why tachycardia?
Torsades, that's a good point.
That's
And that's
Oh,
max.
it's max, you're right.
Yeah,
it's
no,
max,
that's
no,
max.
max, sorry, I got the back.
No, that's
good.
max. That's what I'm trying to figure out.
I know there is one for calcium.
Yeah, there is.